Nephrotic and nephritic syndrome. Nephrotic syndrome features massive proteinuria. Can cause because of that excretion is about more than 40 milligram per meter square per hour of urine excretion, or more than 1 gram per meter square per day. Massive proteinuria is the hallmark of nephrotic syndrome. Spot dipstick will be 3 plus or 4 plus. Protein creatinine PC ratio more than 2. Protein creatinine ratio more than 2. Hypoalbuminemia, serum albumin less than 3 gram per deciliter. Serum albumin would be less than 3 gram per deciliter. Decrease oncotic pressure will cause anasarca. There will be decreased oncotic pressure and will cause anasarca. Hyperlipidemia due to increased production of lipoprotein and lipid by liver. Hyperlipidemia is due to increased production of lipoprotein and lipid by liver. Hyperlipidemia due to increased production of lipoprotein and lipid by liver. Pathology, minimal change disease is most common. Minimal change disease most common. Significant glomerular lesions. Focal segmental glomerulosclerosis. Mesangial proliferative glomerulonephropathy. C3 glomerulopathy. Conditions seen: minimal change disease. Pathogenesis: effacement of negatively charged food processes of podocyte. Minimal change disease. What happens is effacement of negative charged food process of podocyte. Negatively charged proteins are not repelled. Increased excretion of proteins. Management: diet, high protein diet and no added salt. High protein diet and no added salt. Steroid prednisolone, 6 weeks period. First 6 weeks you are giving up to 2 milligram per kg per day daily up to 60 milligram, followed by lesser dose of 1.5 milligram per kg per day on alternate days up to 40 milligram. So for the first 6 weeks you are giving 2 milligram per kg per day up to 60 milligrams daily, and then the following 6 weeks you are giving 1.5 milligram per kg per day up to 40 milligrams on alternate days. Response confirms MCD without biopsy. If there is response to this therapy, then it shows that there is minimal change disease without any biopsy. Protein in urine will be less than 4 milligram per meter square per hour, or on dipstick there will be no protein, and PC ratio will go back to less than 0.2. Diuretic for significant edema. Furosemide. If there is no response, then add spironolactone. Furosemide. If there is no response, then add spironolactone. Course of disease, presentation of illness. There could be remission, there could be relapse, reoccurrence of proteinuria, there could be frequent relapses, more than equal to 2 relapses in 6 months or more than equal to 3 relapses in 1 year. So, reoccurrence of proteinuria, daily steroids, you give 2 mg per kg per day, alternate day steroid 1.5 mg per kg per day, continue for 4 weeks and then stoppage of treatment. Relapse within 14 days again, then it's a steroid dependence. Management is to avoid steroids can lead to toxicity and use immunomodulatory drugs like levamisole or mycophenolate. So if you are suspecting steroid dependency, that it is worsening every time that you are stopping steroids, then you give immunity modulating drugs, immunomodulator drugs like levamisole and mycophenolate. Steroid resistance nephrotic syndrome, that was steroid dependent. Now steroid resistant nephrotic syndrome. Nephrotic syndrome, what is the hallmark? Proteinuria, more than 3 plus 4 plus on urine dipstick and more than 2 protein creatinine ratio. Usually due to significant glomerular lesions, congenital nephrotic syndrome, onset is more than 3 months. So it is usually due to significant glomerular lesions and congenital nephrotic syndromes, and it occurs after 3 months. So that is your steroid resistant. There is too many glomerular lesions and congenital nephrotic syndrome. Investigation, renal biopsy, GFR estimation and genetic testing. Common mutation in congenital nephrotic syndrome. NPHS1 gene phenotype codes for nephrin autosomal recessive. NPHS1 gene phenotype codes for nephrin autosomal recessive. NPHS2 gene codes for podocin autosomal recessive. WTI gene, Danish-Drass syndrome, autosomal dominant, associated with increased risk of Wilms tumor and ambiguous genitalia in male. So there are 3 genes, NPHS1, NPHS2 and WTI gene. NPHS1 codes for nephrin, NPHS2 codes for podocin, and WTI gene is called Danish-Drass syndrome. Both NPHS1 and NPHS2 are autosomal recessive, while WTI gene is autosomal dominant and it is associated with increased risk of Wilms tumor and ambiguous genitalia in male. Management, calcineurin inhibitors like cyclosporin or tacrolimus. So what is the management? Immunomodulatory inhibitors like cyclosporin or tacrolimus. Complications of nephrotic syndrome: proteinuria of decreased immunoglobulins, complement proteins, impaired opsonization, increased risk of encapsulated bacterial infections like streptococcus pneumonia, Haemophilus influenza type B, spontaneous bacterial peritonitis, cellulitis, pneumonia, and decreased anticoagulant proteins like protein C, protein S, plus increased production of fibrinogen in liver, hypercoagulability, infarctions and manifestations, for example stroke. So what are the complications of nephrotic syndrome? Proteinuria, so there is a reduced in complement proteins and impaired opsonization, so increased risk of encapsulated bacterial infections like streptococci pneumonia and Haemophilus influenza type B. There is also spontaneous bacterial peritonitis, cellulitis, pneumonia, etc. Also there is decreased in anticoagulant proteins like protein C and protein S, and there is increased production of fibrinogen in the liver. So there is a hypercoagulability and can cause infarctions and manifestations like stroke. So complications of nephrotic syndrome is infections by encapsulated bacteria and hypercoagulability. Nephritic syndrome, glomerulonephritis. Clinical features: hematuria is a hallmark. Proteinuria is the hallmark of nephrotic syndrome, and hematuria is the hallmark of nephritic syndrome. Cola colored urine. Urine microscopy finding more than 5 RBCs per high HPF field, high intensity field, whatever, more than 5 RBCs. Dysmorphic RBCs, RBC cast, small urine amount, oliguria, localized edema, for example, periorbital, puffiness of eyes, hypertension, and mild proteinuria. There is hypertension and mild proteinuria. Diseases seen as post-streptococcal glomerulonephritis, IgA nephropathy, and hereditary nephritis. Which diseases are seen? Post-streptococcal glomerulonephritis, IgA nephropathy, and hereditary nephritis. Post-streptococcal glomerulonephritis, PSGM. Post-infectious phenomenon, course 7 to 10 days. Pathogenesis: group A beta hemolytic streptococci. Initial infections, pharyngitis or pyoderma. Formation of immune complexes is deposited in the kidneys and will cause nephritis. There is a lag period of 1 to 2 weeks after pharyngitis, M4 M12 strain, and 3 to 6 weeks after pyoderma, M14 strain. Clinical features. Incidence: most common age group is 5 to 15 years, school going children. Male have more incidence than female of nephritic syndrome. Clinical features: abrupt onset of hematuria, oliguria, edema, and hypertension. What is the clinical feature? There is an abrupt onset of hematuria, oliguria, edema, and hypertension. Preceding history of infection not requisite for diagnosis. Degree of oliguria decides disease severity. Complication: hypertensive encephalopathy can cause seizures and left ventricular failure. Hypertensive encephalopathy will cause seizures and left ventricular failure. And degree of oliguria decides the disease severity. Investigations. Antibody titer, estimation of anti-streptolysine O, ASO, and anti-DNase B, additionally in skin infection. Investigation: antibody titer, estimation of anti-streptolysine O, ASO, anti-DNase B, additionally in skin infection. Serum 3C3, decrease in immune complex mediated disorders. Value usually normalizes within 8 to 12 weeks. Serum C3, decrease in immune complex mediated disorders. Serum C3 is decrease in immune complex mediated disorders, and value usually normalizes within 8 to 12 weeks. Renal biopsy is not performed routinely. We do not perform renal biopsies routinely. Indication: persistent low C3 more than 12 weeks to rule out other causes. What are the indications that you persistent low C3 more than 12 weeks to rule out other causes? Systemic illness, high fever, rash, joint pain, no resolution in more than 10 days. So renal biopsy is not usually performed in nephritic syndrome, but it is indicated when persistent low complement C3 level for more than 12 weeks to rule out other causes. Systemic illness like high fever, rashes, joint pain. There is no resolution in more than 10 days. Finding: you will see in electron microscopy subepithelial immune complex deposits in the form of humps. You will see subepithelial immune complex deposit in the form of humps. By immunofluorescence, IgG plus C3 deposition in capillary walls and mesangium. Starry sky appearance. Immunofluorescence, IgG plus C3 deposition in capillary walls and mesangium. Starry sky appearance. Management: self-limiting condition. It is a self-limiting condition. Supportive management of hypertension by amlodipine, nifedipine. No prophylactic role of antibiotics, unlike rheumatic fever. In rheumatic fever, there is a prophylactic role of antibiotics, but in nephritic syndrome, there is no prophylactic role of antibiotics. The supportive management of hypertension is by amlodipine and nifedipine. IgA nephropathy, also known as Berger's disease. It is the most common cause of chronic and recurrent nephritis associated with chronic kidney disease. Pathogenesis: any viral, bacterial upper respiratory tract infection. IgA in mesangium and capillary walls. So IgA nephropathy, also known as Berger's disease, most common cause of chronic and recurrent nephritis associated with chronic kidney disease. Pathogenesis: any viral or bacterial upper respiratory tract infection. Then IgA deposition happens in mesangium and capillary walls. Investigation: C3 level is normal. ASO titer is not increased. Renal biopsy: mesangial proliferation plus IgA deposits. Management: chronic nephropathy, 10 to 20% cases. Chronic kidney disease requires constant follow-up. Management: chronic nephropathy, 10 to 20% cases. Causes it in it 10 to 20% of cases will develop chronic kidney disease, so they require constant follow-up. ACE inhibitors or ARB, angiotensin receptor blockers, decrease renal progression of kidneys, decrease risk of chronic kidney disease. Fish oil, omega-3, PUFA, decrease macrophage entry into mesangiums. No initiating factors for IgA deposition. Hereditary nephritis. Coming to hereditary nephritis, also known as Alport's syndrome. Most common mode of inheritance is X-linked dominant. Hereditary nephritis, also known as Alport's syndrome. Most common mode of inheritance is X-linked dominant inheritance. Genetic defect is COL4A5 gene, alpha 5 chain of type 4 collagen. COL4A5 gene, alpha 5 chain of type 4 collagen. Clinical features: hematuria, high frequency sensorineural hearing loss. An ocular finding, you will have anterior lenticonus, which is diagnostic of Alport syndrome, macular flex, corneal erosions. So what is the triad of Alport syndrome? You have hematuria and you have high frequency sensory neural hearing loss and ocular findings in that anterior lenticonus, which is diagnostic of Alport syndrome, macular flex and corneal erosions. Investigation: gene testing for COL4A5 gene mutation, renal biopsy. Laminations: basket weave appearance, thinning of GBM and thickening of glomerular basement membrane. Thinning of GBM and thickening of glomerular basement membrane. Glomerular basement membrane, thickening of glomerular basement membrane. Thinning of GBM. Management: regular follow-up. Many develop end-stage renal disease by the second or third decade. Supportive treatment: ACE inhibitors to decrease renal progression. In the next video, we will continue with inherited tubular disorders.